Hello everyone. Hello everyone. Today we will be talking about the various regressive alterations of teeth. Regressive alterations of teeth. So as the name suggests, these are some of the changes that happen to the tooth structure over a period of time. We have heard about various age changes that can happen to the tooth surface. Some other factors which can lead to some regressive changes that can cause that can happen to the teeth over a period of time. So we'll see some types of such regressive alterations of teeth. So the first one is attrition. The most commonly heard one is attrition. So attrition is a mechanical wear of the tooth surface, and it happens as a result of functional or parafunctional movement of the mandible. So simply put, it is caused by tooth-to-tooth contact. When tooth surfaces come into contact with each other, they lead to attrition. So this attrition is a continuous age-dependent process which is usually physiological. It can be pathological also. It can happen due to some predisposing pathological factors as well, but it is usually physiological process. When tooth-to-tooth contact occurs, as we can imagine, most common site where tooth-to-tooth contact occurs will be in the occlusal surface. So when tooth-to-tooth contact occurs and due to that a wearing away of tooth surface occur, we can refer to as attrition. So this attrition is a continuous age-dependent process, and it can affect both the deciduous and permanent dentition. And generally, men exhibit more severe attrition as compared to women. Okay, because men have a higher masticatory force, they tend to exhibit it more than female population. This is that occlusal surface attrition is the most common type of attrition seen, seen due to the occlusal surfaces coming into contact, maxillary and mandibular teeth coming into contact with each other. So this occlusal surface attrition can lead to loss and flattening or faceting of the occluding elements. Faceting means there will be a flattened, polished surface formed on the occlusal surface of the tooth. Due to the constant pressure put by maxillary and mandibular teeth on each other, there will be a flattening or a faceting of an occlusal surface. Faceting refers to the flattened polished surface. Facets refers to flattened polished surface, except for example, what we see in diamonds and all. So similarly, we'll have a flattened polished surface of the occlusal surface of tooth. Then there will be loss of vertical dimension. Naturally, when there is wearing away of tooth surface, there will be loss of vertical reduction in height of the crown of teeth. Cheek biting and gingival irritation also occur secondary. So occlusal surface attrition is the most common type of attrition which we see. Sometimes we can also see proximal surface attrition. Rarely we can see proximal surface attrition also. So in such cases, there will be widening of the proximal contact area. The proximal surface, usually proximal surfaces are in contact with each other at one single point. So here there will be, due to wearing away of that contact point, there will be widening of the proximal contact areas. And also, as we can imagine, there will be decreased mesiodistal width of the teeth. There will be loss of vertical dimension of teeth in occlusal surface attrition and decreased mesiodistal width of teeth in proximal surface attrition. Various predisposing factors I mentioned earlier, there are some predisposing factors which can increase the chances of attrition, and the most major one is bruxism or night grinding. So bruxism is a habitual grinding or clenching of the tooth, which mostly occurs during sleep. It's one of the most common sleep disorder. So patients who have issues like anxiety, stress, emotional tension, etc., they have a tendency to clench their teeth during sleep, which, as you can imagine, puts a high masticatory load on the teeth and can lead to attrition, occlusal surface attrition. So also lead to integrity, a loss of integrity as this bruxism keeps on going on for a longer period of time. There could be a loss of integrity of periodontal structures. There can be disturbances happening to TMJ due to constant load befalling the TMJ, and there can also be hypertrophy of masticatory muscles due to constant working of the masticatory muscles. There could be hypertrophy, especially of the masseter muscle. So bruxism is the most common predisposing factor. Another one is amelogenesis imperfecta or dentinogenesis imperfecta. These are hereditary conditions which make the tooth soft. So these structures also can lead to higher risk of attrition. The clinical manifestation, untreated teeth will have a small polished facet, the polished flat surface on a cusp tip. That is a classical appearance. And with that, there will be gradual reduction of cusp height. Flattening of the occlusal surface occurs with aging. And over a period of time, it can lead to tooth sensitivity. As the regressive alteration progresses to the dentin, it can lead to tooth sensitivity, and TMJ problems can also be elicited. So over a period of time, the vertical height of the teeth decreases, leading to flattened, faceted appearance of the tooth. In some older patients, instead of the classical flattened, faceted appearance of the tooth, the enamel of the cusp tip can get cupped out areas. Just as we can see in this image, there will be cupped out areas because the dentin wears faster than the surrounding enamel. So in such cases, instead of a flattened, classical picture of a flattened flat facet, we'll see cupped out areas of tooth surface because dentin gets destroyed faster than the surrounding enamel. It can also take up stains over a period of time. It can also take up stains of food material or tobacco, etc., can give a yellowish brown appearance. So that was with attrition, and as we saw, attrition is a regressive alteration which is caused by tooth-to-tooth contact. Next one is abrasion. So abrasion is an abnormal tooth surface loss resulting from frictional forces between teeth and external objects. Okay, so it's caused by frictional process between the attrition was caused due to friction forces between two tooth surfaces. Here it is caused between the teeth and one external object. So there will be some abnormal mechanical process involved in the wearing away of tooth surface, and the most important causes for this is abnormal tooth brushing habits and other abnormal chewing habits. So these are the two main factors which can lead to abrasion. Improper brushing technique is the most common positive factor for abrasion. Horizontal brushing techniques, which is used by most people in the population who doesn't have a proper awareness about proper brushing techniques, use horizontal method, and this produces a strong force on the tooth surface, and this is the most important cause for abrasion. So this can be compounded by the use of abrasive dentifrices. Dentifrices to toothpaste containing more abrasive contents, hard toothbrush bristles, etc., can compound to this problem. Other habits such as holding a pipe stem by the teeth, opening of bobby pins with the teeth, etc., can also cause abrasion of tooth surface. There will be notching of the incisal edges of the maxilla, especially in people holding pins or needles in between their teeth, like tailors. They will have a notching of the incisal edge of maxillary central incisors. Carpenters, tailors, shoemakers, etc., who hold nails, pins, etc., between the teeth can have a typical abrasion of one particular area of tooth where they are holding these needle in their tooth. So that such habits can also cause abrasion. Improper use of toothpicks, dental floss, etc. can also lead to abrasion. So the clinical picture which we see in abrasion, they will have a typical V-shaped or wedge-shaped ditch on the root surface of cemento-enamel junction. It will have a typical V-shaped or wedge-shaped ditch. They will have a V-shaped or a wedge-shaped ditch in the cervical region, root part of the cemento-enamel junction. So naturally, there usually will be associated with gingival recession, and there will be a V-shaped ditch or a wedge-shaped ditch in the cervical region. So they have a very characteristic appearance, and this ditch usually has sharp margins, as opposed to the clinical picture of attrition, where we saw flattened, polished surfaces. Here we see V-shaped ditches with sharp margins, sharp internal line angles, etc. will be seen. So that is a classical picture of a clinical picture of abrasion, tooth abrasion. So since cervical area is the most involved, many times we also refer to the condition as cervical abrasion. And canines and premolars are the most affected teeth. As I said, the most common cause for abrasion is toothbrushing, faulty toothbrushing techniques. And in this type of brushing techniques, most of the pressure will be put on the opposing canines and premolars. So these teeth are the most common teeth which demonstrates tooth abrasion. In case of people practicing pipe smoking, you see depression abrasion coinciding with the intraoral location. Where habitually, they will have a one particular site where they will be holding the pipe all the time. There you will see a depression in the shape of the pipe stem which they are holding, and the teeth which is mostly associated with the which they use to hold the pipe usually show the depression abrasion. Chewing tobacco can cause generalized occlusal surface abrasion. Then in such cases, attrition and abrasion occurs together. Pica syndrome, people having the psychological problem of Pica syndrome, which is a habit of chewing mud or clay, etc., sand, mud, clay, will also naturally have a occlusal abrasion. Again, a generalized occlusal abrasion. So this is a picture showing an advanced case of cervical abrasion. Here also, the V-shaped or wedge-shaped ditch is very clearly present in all the cases in the cervical region, root part of cervical region, V-shaped wedge with sharp margins and internal line angles are seen. So that's with abrasion. Next one is erosion. Next regressive alteration which can happen is erosion. Now, erosion is an irreversible loss of dental hard tissue by a chemical process that does not involve bacteria. Okay, it is caused by chemicals, mostly acidic materials, but does not involve bacteria, which rules out dental caries. So any other type of loss of tooth structure caused by chemicals or acid is referred to as erosion. So usually this acids or chemicals which can cause the loss of tooth structure, dissolution of the tooth structure, can be an intrinsic source of acid, like in case of gastroesophageal reflux or vomiting, or it can be due to some extrinsic source of acid, like the acid content in diet. So they can be broadly the causative factors which can cause erosion can be divided mainly into two types: extrinsic factors and intrinsic factors. So the extrinsic factors, it involves dietary acids, citrus fruits, fruit juices, etc., pickled fruits, acidic beverages, some medications, etc., which have a higher acidic content, can cause act as extrinsic factors which cause erosion. Environmental erosion, wine tasting, battery manufacture, etc. People associated with such occupations such as wine tasting, battery manufacture, etc., can also experience extrinsic loss of erosion. Intrinsic factors which comes from the body involves various gastric disorders like gastroesophageal reflux disorder, chronic excessive vomiting, any condition associated with chronic excessive vomiting, gastrointestinal ulcers, gastritis, etc. acts as important causative factors of intrinsic, because gastric content is highly acidic. The pH within the stomach drops down between 1 to 2. It's a highly acidic environment. So any condition that can cause a reflux or regurgitation of the gastric content into the oral cavity can lead to can act as intrinsic factor, which can lead to erosion of tooth surface. There is eating disorders like anorexia nervosa or bulimia nervosa, etc. are psychological conditions again associated with chronic vomiting, can all lead to, or other conditions, physiological conditions like diabetes mellitus, pregnancy, people with chronic alcoholism, where this chronic, all associated with chronic vomiting can lead to erosion. They all act as intrinsic factors of erosion. So the clinical presentation of erosion usually is presented as broad, shallow, saucer-shaped defects involving enamel and dentin. Here we will see a broad, shallow, saucer-shaped defect with no sharp line angles and margins. There will be a depression on the concavity on the tooth surface. If it's caused by extrinsic agents, it's usually found on the buccal or labial aspect of the teeth. If it's caused due to intrinsic factors, you will see usually on the lingual aspect of the teeth. So they will be seen as saucer-shaped defects, concavities on the tooth surface with a smooth margins. They will have smooth margins. Unlike abrasion, which we sharp internal line angles and margins, here we will see no sharp line angles and the margins of the defects will be smooth. So they will blend with the normal surrounding normal tooth surface. Again, the surface appears smooth and polished. So the most common site of occurrence is the palatal surface of the maxillary anterior. Most of the causes of erosion are caused by the intrinsic factors of the factors. It's mostly presented on the palatal surface of maxillary anterior. Exogenous agents, as I mentioned, usually causes defects in the labial surface, and with time it can cause tooth sensitivity. This is a case of advanced tooth erosion. So that's the tooth erosion, which is caused by chemical agents. Next one is abfraction. Abfraction is a comparatively recently defined regressive alteration of the tooth. Many of the cases of abfraction were earlier confused with or diagnosed as abrasion, cervical abrasion. Now, abfraction is a pathological loss of tooth substance due to biomechanical loading force that results in a flexure. Every time the patient masticates, maxillary or bites maxillary mandibular teeth come into contact with each other, they produce a force upon each other, and due to this there will be a slight bending at a microscopic level. There will be a slight bending of each tooth happening every time they come into contact with each other. So this bending can lead to loss of small microscopic fracture and fracturing away of small amounts of teeth surface from the cervical area. Each time the teeth come into contact with each other, there is bending of the teeth happening, which cannot be appreciated with our eyes. In a microscopic level, bending will be happening, and due to that, small amounts of teeth will be separated from the tooth surface, cervical area of the tooth surface. So this again will lead to loss of tooth from cervical area, which will give an appearance which will be almost same as that of an abrasion. The cervical region, you will see V-shaped or wedge-shaped defect with sharp internal line angles. So this is the reason why it is often confused with cervical abrasion. So here also the clinical features, they appear as wedge-shaped defects on the facial aspects of teeth. Often it will be towards the buccal or labial aspect because the flexure happens towards the buccal or labial aspect. So they will have sharp margins and internal line angles. So that is abfraction. Abfraction is a comparatively recently defined type of regressive alteration. As I said, many of them might have been reported as cervical abrasion. So these conditions, attrition, abrasion, erosion, or abfraction, they usually will have the same sequelae. That is, as the tooth structure getting involved, there will be exposure. The enamel will get worn off. Then there will be exposure of dentinal tubules, irritation of odontoblastic process, there will be tertiary dentin formation, and there will be other sclerotic dentin formation, tertiary dentin formation, which will intend in protecting the pulp. We will try to protect the pulp. So this will be the sequelae, which will be common for all these with attrition, abrasion, erosion, and abfraction. So various dentinal changes that can happen as regressive alterations involved. Dentinal sclerosis. The dentinal sclerosis is a calcification of dentinal tubules. The contents within the dentinal fluid within the dentinal tubules gets deposited, the calcium content, and there will be calcification of dentinal tubules, which will try to seal off the dentinal tubules. That is dentinal sclerosis, and this dentinal sclerosis either can happen as a normal aging process, or it can happen as because of an injury to the dentine due to dental caries or attrition or abrasion of things or any of such factors. It can happen as a response for protecting the pulp. So microscopically, they appear as a translucent zone or a glassy appearance. In ground sections, they appear as a translucent zone. The exact mechanism is not known, but it is believed that the calcium, the mineral content within the dental limb or dentinal fluid, gets deposited and leads to calcification of dentinal tubules. So sclerosis naturally decreases conductivity of the odontoblastic process, and thus it helps in protecting the pulp. Tertiary dentin formation is a dentin formed after the complete tooth formation in response to an abnormal stimulus. After the primary and secondary dentin as it is getting formed, if there is an injury to the dentin structure, in response to the injury, tertiary dentin, an abnormal stimulus, in response to an abnormal stimulus or an injury, tertiary dentin will be deposited. So this tertiary dentin can be of two types, reactionary dentin and reparative dentin. So if an injury occurs and some odontoblastic processes are involved, but the odontoblast remain intact, they will produce reactionary dentin. The odontoblast present in the periphery of the pulp will produce reactionary dentin. But if odontoblast gets destroyed and a new generation of odontoblasts are differentiated from the already existing from the pulp stem cells to form new tertiary dentin, we call it reparative or regenerative dentin. Okay, reparative or regenerative dentin. So the tertiary dentin will have fewer irregular and more twisted tubules, which will block the irritant from reaching the pulp. It will be different from in physiology from primary and secondary dentin. And sometimes, due to the rapid rate of deposition of the tertiary dentin, the odontoblast may get entrapped within the dentin matrix which will give it a bone-like appearance, which has been referred to as osteodentin. So sometimes in the tertiary dentin histology, we may see a osteodentin-like appearance. The next regressive alteration is pulp calcification. So pulp calcification, as the name suggests, they are calcified bodies which can occur within the pulp tissue, either within the pulp chamber or root canals. There might be formation of calcified bodies. So the calcifications within the pulp can be of three types: denticles, pulp stones, or diffuse linear calcification. Denticles, pulp stones, or diffuse linear calcification. The denticles, or as we call them, true denticles, are actually calcifications within the tooth surface. It is more of a developmental disturbance than a regressive alteration. True denticles are usually formed during the period of root development, and it is believed to form as a result of epithelial-mesenchymal interaction of some Herdwick's epithelial root sheath, which may have gotten entrapped in that region within the developing pulp. So it is believed to be a developmental disturbance, which is caused as a result of epithelial mesenchymal interaction of Herdwick's epithelial root sheath and the developing pulp tissue. The true denticles can occur in root canal or pulp chamber. It's closer to the furcation area. It's more rare to see true denticles towards the coronal part of the pulp. Is more found in the root canals plus the furcation areas of multi-rooted. So they're referred to as true denticles. The reason we call them true denticles is because histologically they will have a structure resembling dentine, a tubular structure resembling dentine. So the true denticle, we can divide them based on their location within the pulp tissue. We can divide them into three types: pre-denticles, which come entirely within the pulp tissue; attached denticle, which will be attached, it will be continuous to the wall of the dentine. They will be present within the pulp tissue, which will be attached to the wall of the dentine; and embedded denticles, which will be embedded within the walls of the dentine. Next one is false denticle or pulp stones. The false denticles or pulp stones are the actual regressive alterations of the pulp, which produces a concentric lamellae of calcification around a central nidus. So within the pulp tissue, you will see concentric lamellae of calcifications around a central nidus, which may be formed of reticular fibers or ground substance, etc. So false denticles will be found more in pulp chamber. They may usually arise as a part of an age-related or local pathologic changes. They usually occur as a result of age changes or local pathologic changes. They mostly develop after the tooth formation is completed, as opposed to the true denticles, which occurs mostly during the development of the root, and they can be usually free or attached denticles. So there's a third type known as interstitial denticle, which is an attached false denticle. It's not embedded yet, but it's an attached false denticle over which a layer of dental tubule-like structures are. The third type of pulp calcification is diffuse linear calcification, which is more like false pulp stone, but they will be found more towards the root canal regions, which will give them a linear shape instead of the concentric lamellae in a circular shape, which we usually see in the crown region. You will see linear calcification. So that is only difference. Other than that, it will be quite similar to a pulp stone or false denticle. So their frequency usually increases with age. Diffuse linear calcification, their number usually increases with age. So the pulp stones, they usually have very little clinical significance. The most important clinical significance associated with pulp stones, they will be usually asymptomatic. The most important problem caused by them is obstruction to endodontic treatment. Resorption of tooth is the next regressive alteration. So the resorption of tooth can be physiological or pathological resorption. Physiological resorption is a process of resorption of deciduous teeth. The root of the deciduous teeth gets resorbed due to the pressure created by the succeeding permanent teeth. So that is the example of physiological resorption of teeth. So the resorption of teeth is usually caused due to three factors. One is pressure. As we saw in case of the physiological resorption, the pressure is created by the succeeding permanent teeth on the root of deciduous teeth. So pressure is probably the main factor. There should definitely be the role of odontoclast, which will have to resorb the tooth surface. And there will be humoral mediators such as prostaglandins, which will help with the resorption. So there are two types of resorptions, internal resorptions and external resorptions. So external resorptions, it can occur due to various different types of causes, like in association with periapical inflammation. In cases of reimplanted or transplanted teeth, there is a high chance of resorption of the root surface. Pressure created by tumors or cysts, etc. Impacted teeth may cause pressure on the root surface. So there are a lot of factors which can lead to external resorption, which happens usually on the root surface. The regressive alteration is mainly associated with internal resorption of teeth, which is also usually referred to as pink tooth or pink tooth of mammary or odontoclastoma. In such cases, there will be resorption of the internal surface of the pulp walls. So due to that, there will be a pinkish appearance. As you can see in the adjoining picture, the tooth surface will show a pinkish appearance because there will be resorption from the internal dentinal wall, which will thin the tooth structure, and the underlying pulp, which usually will be inflamed and will have granulation tissue with high vascularity, will be reflected out in a pinkish hue. So this is a typical appearance of internal resorption or a pink tooth. So because the pulp tissue usually will be having granulation tissue, it's also referred to as internal granuloma. And because of the presence of odontoclast, which causes the internal resorption, it's also referred to as odontoclastic. So it's caused by usually by inflammatory hyperplasia of pulp. Tends to be localized in one region and can affect any part of the disease. The crown, as we saw earlier, where it will be manifested as the pink tooth, or it can also occur on the root, as we see in this IOPA radiograph. It could be resorption in the root area also. Clinically, appearance of a pink hue area will be seen on the crown. It keeps on progressing. Instead, and if the pulp undergoes necrosis, instead of the granulation tissue, it will show black color instead of the pinkish hue. You can see here, clinically we can see one pink tooth, and the left central incisor shows a blackish color because already there is necrosis of the tooth surface. And in the radiograph, we can identify both these tooth have undergone internal resorption. So radiographic features, as we can imagine, they will be seen as well-defined round or ovoid area of radiolucency in the central portion of the tooth associated with the pulp. In the central portion of the tooth associated with the pulp, will see a well-defined area of radiolucency. And long-standing lesions may finally cause perforation of the tooth surface. Histologically, variable degree of resorption can be seen on the pulpal surface of the dentin, and this will always be lined by odontoclast. Hence, we call it odontoclastoma. So the walls, the internal walls of the dentin where the resorption takes place will be lined with a large number of odontoclasts. The pulp tissue will show chronic inflammatory reaction. Usually, it will be a granulation tissue with large numbers of chronic inflammatory cells. And so, as a result, there will be hyperplastic, highly vascular pulpal granulation tissue, which gives that a high vascularity, will make the tissue more reddish, which will be reflected with the pink hue through the thin dentin and enamel wall. So, usually this pink tooth is untreatable. You can do endodontic treatment if we are able to notice it in the earlier stages, we can do the endodontic treatment. That is internal resorption of teeth. Finally, there is hypercementosis of root surface. So, as the name suggests, hypercementosis refers to excessive deposition of cementum on root surface. Excessive deposition, which may be localized or generalized. It may be seen in one area associated with one particular teeth, or we may see a generalized hypercementosis, such as all the teeth in a quadrant or all the teeth in an arch may get involved in some cases. So mostly the hypercementosis involves the entire root area. Some cases will show only deposition of cement only in the apical area. So the important etiological factors which can cause hypercementosis include accelerated elongation of tooth. So if in case there is an absence of an opposing tooth, supraeruption of a teeth can occur. So in case of supraeruption, is an abnormal accelerated eruption of tooth, which is often caused by elongation of the root. So this can lead to hypercementosis. Then periapical or periodontal inflammation, various inflammatory mediators will be involved in such inflammation around the apical region of the root. And this can lead to activation of cementoblasts and production of more cementum, leading to hypercementosis. Tooth repair, again, when the root tries to compensate for occlusal trauma, root fracture, etc., and starts producing cementum very fast, rapidly, can lead to hypercementosis. And then an important systemic disorder which can lead to generalized hypercementosis is Page's disease, which can cause generalized hypercementosis throughout the mouth. Multiple teeth, like I said, maybe in one quadrant, the whole teeth in one quadrant or large number of teeth in one particular arch may show hypercementosis, and often that can be a sign of Page's disease. So again, the clinical significance is not that much, and usually there will be asymptomatic. Radiographically, there will be thickening and apparent blunting of the roots, and the root lose their typical shape. Instead of sharpened appearance, they will have a more blunted, round appearance. Histologically, there will be excessive amounts of secondary cellular cementum or osteocementum over a thin layer of primary acellular cementum. So there will be they'll be arranged in concentric layers around the root, and you also see a loss of resting lines. As you can see in the image here, you will also see a lot of resting lines in the root surface, which are hematoxyphilic lines, which mark past successive deposition of. So those are the various regressive alterations which can affect the tooth structures, which we have discussed: attrition, abrasion, erosion, abfraction, dentinal changes, pulp calcification, resorption of teeth, mostly internal resorption of teeth, and hypercementosis.